I'm now going to talk about mechanisms in retinal malapposition, including retinal displacement. So let's go back to our patient who had severe anisoconia despite good visual acuity. If we look at the fundus autofluorescence, we see these hyper-autofluorescent lines indicating the location of the retinal vessels before the detachment, and we can see that the retina has shifted. This is a patient following pneumatic where we don't see those hyper-autofluorescent lines, where the functional outcomes were better. So with a multi-center study group, we assessed the risk of retinal displacement, and we found a 50% or 45% risk in the vitrectomy group, which is consistent with the literature out of Japan, out of Italy, out of the UK. But what was different was that the risk of retinal displacement is significantly less with pneumatic retinopexy at 7%. We followed this up with a prospective clinical trial which corroborated these findings with the same risk in the fovea off group in the macula off patients who had vitrectomy versus 14% in the pneumatic group, again showing a significant difference. We also recently completed a study comparing buccal versus vitbuccal, and again found that in the vitrectomy group there was a significantly greater risk of retinal displacement. So why does this happen? Well, we know that there's always some subretinal fluid that's left behind at the end of surgery. This subretinal fluid gets displaced by the buoyant force of the large gas bubble, and as this fluid is displaced inferiorly, it stretches the thin elastic retina, leading to retinal displacement. Now, while we were trying to figure out exactly what was going on, we thought, okay, let's be smart here. Let's inject perfluorocarbon liquid and avoid the air-fluid exchange and avoid the gas altogether. So we shouldn't get any displacement if it's due to the tamponade. If you see here, we're putting in the PFCL very slowly, and you can see the fluid going infratemporally. That's very important. We got the worst displacement we've ever had. And why? Because we then understood that it's not the specific technique, but it's the fact that we're moving fluid. When you iatrogenically displace fluid, you're going to get retinal displacement, whether it's PFCL with an endotamponade, whether it's a gas bubble, or whether it's even scleral buccal with drainage. When you drain with a scleral buccal, again, you're forcing fluid to move in a certain direction, and then when the drainage stops, it stops when it's stuck to the buccal, and it stays in that stretched position. I want to take a minute just to differentiate slippage versus displacement. We know that when we have a giant retinal tear, for example, we inject perfluorocarbon liquid, we flatten out the retina, we do our laser. There's always some anterior fluid that we can't get. Now, when we drain the fluid, we try to minimize that as much as possible, as much as we can, but we know that there's always a chance of that fluid migrating posteriorly. Think of slippage and macular folds as a redundancy in the retina posteriorly. When you have redundancy posteriorly, the retina has to be stretched anteriorly. So you have stretching anteriorly, redundancy posteriorly. That's what you get slippage and macular folds. Retinal displacement is the opposite location. You get stretching in the macula and redundancy in the inferior periphery where the fluid's been displaced. So what is the problem with retinal displacement? Well, we know that it causes anisoconia because it's stretching the macula. You have increased cone spacing, and that's why all your patients are going to say after vitrectomy that we see objects as smaller and pinched in. I want you to see this case of a supratemporal detachment. Here you can see in panel B mild retinal displacement, but in this case we had a FAF before the patient ever had a detachment, and if we overlay it, we see severe displacement temporally. That's much less on the FAF. And we know that we don't always have a FAF before the retinal detachment, but Kobe Brosh in Israel, one of our ex-fellows, developed this technique with homography, where if you happen to have an OCT before they got a retinal detachment, you can align the infrared images using RP and choroidal landmarks, and you can color code them, see the movement of the retina. And it turns out that 100% of vitrectomy cases have this shift of the retina and have this displacement. Thank you.
Thank you once again. So I've gone through the stages of detachment, but what happens to the fovea? So last year we started studying the fovea in detail in a prospective study with only fovea off detachments and baseline OCT, and we found that almost 24% of patients have evidence of bacillary layer detachment, with some having an inner lamellar hole that invariably progressed to a full thickness macular hole. So this year we decided to investigate the pathophysiology of secondary macular holes and detachments. We did a larger retrospective cohort study, including 360 patients. And again, we confirmed that almost 23% of patients have ballot-related abnormalities in baseline OCT. 8% of our cohort had associated macular holes, but most importantly, 80% almost of these macular holes were actually ballot lamellar holes. And what are those ballot-related abnormalities we've been talking about? So we know that ballot is an introphotoreceptor splitting within the myoid zone, and here we have OCT scans demonstrating its abnormalities, and here in figure 1 we have a minimal split extending to a larger cavity in figure 2. In figure 3 we have the anterior disruption of the anterior ballot walls from this adjacent cystic changes, and finally in figure 4 we have the loss of the Mueller cell cone, and then we have a result with the so-called ballot lamellar hole. And what seems to be the main reason why the fovea has such unique abnormalities is because of the intricate arrangement of the central atypical Mueller glia. And these cells, they lack connection with the typical Mueller cells in the foveal walls, and they have a watery cytoplasm. And all these distinct characteristics were hypothesized to impact on foveal stability and result in degenerative and tractional abnormalities. So with the assistance of histological sections of normal foveas, we started observing tissue disruptions very similar to those that we observed in the OCT, suggesting that our 4 areas of a low mechanical stability in the fovea, which are the RPE photoreceptor interface causing the detachment, the myoid zone leading to the ballot, the Henle fiber layers around the foveal walls, which leads to the disruption of the ballot walls, and finally the Mueller cell cone and surrounding tissue leading to the ballot lamellar hole. And once you get a ballot lamellar hole, it will progress to a full thickness macular hole, either in the detached or in an attached state, and this is clinically relevant. Presenting with a ballot lamellar hole had worse visual acuity at all time points, even when we compare to ballot, to early ballot or ballot in different spectrum of the disease. So this is, just to conclude, our hypothesis is that outer retinal corrugations are formed as a compensatory response to compressive forces generated from dehydration and lateral expansion of the introphotoreceptor matrix. However, the Mueller cell cone prevents the fovea from corrugating, which leads to a stretch in the cone bouquet and resulting in ballot. Once you get ballot, further damage to the anterior ballot walls from these adjacent cystic changes may result in instability and loss of the Mueller cell cone, resulting in ballot lamellar hole. And then once the retina is reattached, the remaining bridge of introphotoreceptor matrix and photoreceptor segments will then degenerate, leading to a full thickness macular hole. So in conclusion, we need to remember that almost 20% of RDs may have ballot abnormalities, and ballot is crucial in the formation of macular hole due to 4 areas of low mechanical stability, which is RPE photoreceptor interface, the myoid zone, the Henle fiber layer, the foveal walls, and the Mueller cell cone. And once you get a ballot lamellar hole, you will progress to a full thickness macular hole. Therefore, urgent intervention in ballot, in documented cases of ballot, may be beneficial. Thank you very much.
So I'd like to talk about the mechanisms of reattachment following scleral buckling and vitrectomy and how they may be similar in some ways. So building on my previous comments about outer retinal recovery, we've talked about how retinal recovery is rapid, forced, relatively turbulent, with bulk directional flow and displacement from a large gas bubble during transretinal drainage at the time of past plantar vitrectomy. Whereas with pneumatic retinopexy, the gas bubble is steamrolled to occlude the retinal break. And although you do get subretinal fluid evacuation through the break initially, as we alluded to, the final approach of the RPE to the retina is governed by the RPE. It's then followed by retinopexy. So, scleral buckling is a kind of magic, really. How do we achieve retinal reattachment? By approximating a scleral indent to an open retinal break, particularly if you don't drain. So there may be an element of reduced vitreous traction on account of the scleral indentation. Undoubtedly, the retinal pigment epithelial pump plays a role, but the bulk drainage of subretinal fluid or expulsion of subretinal fluid is a result of Bernoulli's principle of lamellar flow. This is the phenomena that's used in airplanes. This is a phenomena whereby the velocity of the fluid traveling up the indent, particularly on saccadic eye movements, which is why after a scleral buckle, we encourage a patient to mobilize, results in a localized reduction in pressure, which encourages the fluid to egress through the retinal break. So both scleral buckling and pneumatic retinopexy share similar mechanisms: slow retinal reattachment, physiological drainage of subretinal fluid, relatively gentle evacuation of subretinal fluid, even if you do an initial drain, and less bulk directional flux of subretinal fluid than, say, for example, a vitrectomy. So we've talked about in vivo reattachment after pneumatic retinopexy, and what I have observed is a very similar course of events following scleral buckling. So this is a patient with a macular off detachment. You can see at baseline turgescence and some corrugations of outer retina with intraretinal cysts. 4 hours after placement of the band, remarkably, there's just a suggestion of some initial outer retinal recovery. 24 hours later, you see the subretinal fluid is clearing. This is a non-drainage technique, I should specify. I don't tend to drain. And you can actually see that the recovery is following the steps that we have discussed in the previous presentation, albeit each step is rather prolonged after scleral buckling. My experience in clinic is that we don't see displacement. We see good outer retinal recovery, but there is much less data after scleral buckling than there is after pneumatic retinopexy. So a meta-analysis has recently suggested that you get most retinal displacement after vitrectomy and perhaps least after a scleral buckle, but we really need more data. So scleral buckling may have the lowest rates of retinal displacement. Likewise, in the SPR study and recent meta-analyses, it's possible that you get the best vision after scleral buckle versus vitrectomy. However, I'm not sure cataract was fully accounted for, and again, we need some more contemporary data on scleral buckling, including multimodal imaging, to draw this conclusion. To summarize, buckling and pneumatic retinopexy share fundamentally similar mechanisms of action and may share the same advantages over vitrectomy. And this really means that while we gather more data, we as surgeons should be maintaining a very diverse skill set to make sure we give our patients the best functional outcomes. Thank you.
Hoover, yeah.
All right, so as I was saying, the anisoconia we were talking about is obviously not good, and we were introduced to this topic of drainage versus pneumatic, which is more gentle reapproximation of the photoreceptors, and we were thinking, what is it about the actual surgical technique which may cause it? Is it drainage itself? Is it the type of drainage? And so we wanted to look at this a little bit more closely over time. So when we follow patients just with vitrectomy for 2 years, we see that vision kind of restores within the first 6 months and slight, variations thereafter, which we're all familiar with. And when we're looking at the reapproximation of the retina on the microstructural level, we see that, the retina is going to repair, but you still have these little pockets of discontinuity. And what does this look like over time? Well, the EZ and ELM will restore quite rapidly within the first 6 months. We see a significant change, but the interdigitation zone is a lot slower to reconstitute, and that may vary with technique as well. So we wanted to look at what technique, if any, is advantageous and what may hinder this. So looking at drainage through a peripheral retinal break versus a posterior retinotomy versus assistance with perfluorocarbon liquid. When we looked at and compared these three types kind of head-to-head, looking at 300 consecutive eyes, 100 in each group, we see that discontinuity of the ellipsoid zone and interdigitation zone were higher with PFCL use, and at 12 and 24 months, we see there's still more discontinuity of these outer retinal critical segments. And we see here is an illustration of some persistent microstructural changes, which we may be familiar with when we're looking at those on OCT. And what does this mean for vision? Well, visual recovery was actually better with drainage through the retinal break compared to PFCL, which was the lowest, and in the middle somewhere was drainage with the retinotomy. So when we kind of break this down a little farther, we did see more epiretinal membrane formation with the drainage retinotomy, which makes sense, that's already previously known, and there was a slightly higher amount of CME with the PFCL group. I'll just pass by those for time's sake. So in conclusion, there's less visual recovery seems to be inferior with PFCL use. As well, seems to be better or more advantageous to use drainage to the brake when possible, and there's less ERM and CME with the drainage to the peripheral retinal brake as well. And those changes in the OCT persist out to 24 months and seem to be higher with the use of PFCL. So PFCL, what is it about? Well, we've been talking about this already, but there is a posterior to anterior stretching of the retina, as well as a more forceful egress of fluid. And these photoreceptors are likely already very friable, and so if you're rapidly approximating them, you would think they'd incur some more damage than when there's a little bit of fluid left. So what about non-drainage or minimal drainage? Well, we're kind of starting to discuss this. Anatomical success rates seem to be normal, or at least similar between the two, and so it doesn't seem advantageous to completely dry the retina. In fact, you may end up hindering reconstitution of the outer retina, at least on the OCT level, but it does seem to corroborate quite well with visual acuity and anisoconia. So the use of PFCL on our hands is to reserve it for those more complex cases that do require assistance and not for routine use. And when possible, drainage to the pre-existing retinal brake seems to be and confer the best visual outcomes in terms of microstructural integrity, but also vision and less secondary complications. And that's it.
Thank you, Brian. That was...
No, I have so many questions,
All right.
but I'm just going to ask the one, which is, how do you explain the findings of the post-RD study? Because in that study, we postured patients with bubble to support the brake, leaving some residual subretinal fluid. And the other group of patients were postured face down immediately for 24 hours, in both cases 24 hours. Now, if I understand what you're saying here, the group that was postured to support the brake, the fluid should have reabsorbed gradually, and they should have had less displacement and less outer retinal folds. But what we actually found was the ones that were postured face down had much less retinal displacement and far fewer retinal folds and much lower risk of diplopia. I don't see how those two fit together.
Yeah, well, we've spent a lot of time looking at that paper as well and thinking about it, and this is what my assessment is. The cause of retinal displacement is a large gas bubble displacing fluid. Whether you position a patient, in the post-RD trial, everyone had a complete air fluid exchange. So if you look at the difference between groups, there was a significant difference, but there was still a high rate even in the face-down group. It was in the 30s, mid to high 30s, and in the position of the brake, it was higher. So despite how you position the patient, the fact that you have a large gas bubble, that large gas bubble is going to push fluid in a certain direction in a gravity-dependent manner, and we think that the displacement happens almost immediately. So when the patient is wheeled out of the OR, you lift their head up, or you give them a coffee and a tea, or they go to the washroom because they've been lying down for a few hours, or that's when it happens. So whether you go home and do face down or position to the brake, it's too late at that point. In regards to the outer retinal folds, I also think that you were still doing a complete drainage. And so regardless of the positioning, the drainage, I'm assuming, was the same. So what we're suggesting is that when in that stage 2, when the corrugation's resolved, that's a slow, natural process that takes a few hours. And so regardless of how you're draining, or positioning, I still think that you're going to have less time in stage 2 to allow those corrugations to go away. And so I don't think that the technique would make a huge impact on the risk of outer retinal folds. I do think that the face-down positioning, which is the very valuable piece of information from that trial, which confirmed some of the thoughts of Shiragami and others, was that immediate log roll to face down is probably the best position to minimize displacement, and many of us now are even thinking about supine positioning. The problem is when you raise the head and you move fluid to the inferior periphery is when you get stretch. If you position them immediately face down, that fluid gets displaced probably in all directions, and so you're minimizing the unidirectional flow of fluid. So I think it's very complex, and I think that was a great study, but so I think it still makes sense. Yeah.
Well, yeah, so in summary, supine face down, I think the bubble is in a neutral position with relation to the macula. So you get displacement, but it's actually sort of centrifugal rather than directional. I think that's different as I understand it.
Yeah, I think it's spreading the forces out, whereas if you're pushing, like we saw in the PFCL case, or in a scleral buckle with drainage, if you have the direction of flow from point A to point B, and the vector force is all in that one direction, you're going to get the displacement in that direction. When you've neutralized that, you're probably minimizing the forces.
Thank you, Rajiv. I'm Dr. Dinesh Tulbar from Delhi, and I must thank you and your group for disrupting our thinking, which had become sort of fossilized, and thinking afresh about the way we are managing our patients. So that's something we need to do, and I think somebody should do it every decade or so. Some questions I have. One was, you actually, during one of the presentations, somebody said that I think a significant percentage of the patients who were in the vitrectomy group were failures of the pneumatic retinopexy group. So I wanted to know whether the pneumatic retinopexy plus vitrectomy group had a disproportionate number of patients who had all these problems of displacement or not. Because this is one issue that could change the entire approach to what you're talking about. The second thing is about what Byron was saying. It makes sense that when you do drainage from a peripheral break, you can't do a complete drainage. So unless you put PFCL. If you put PFCL, you're in a better position to do a complete drainage. If you don't put PFCL, you can't do a complete drainage. So you're leaving residual fluid, and even that residual fluid seems to be enough to improve the results. That's the second thing. But the third, more important thing, as far as I'm concerned, the rate of absorption of fluid from the RPE once you tamponade a break is something like 1,000 microliters per hour, per day. Sorry, it's more or less equivalent to the aqueous drainage, 2 microliters per minute. That's enough to remove any amount of fluid that you have in a detachment, regardless of whether it's pneumatic retinopexy, regardless of whether it's a vitrectomy or if it's a buckle. So this interdigitation cannot occur that fast. It's not that it'll be very fast in a vitrectomy and very slow in a pneumatic. It'll be more or less the same, because by the end of the day, the retina would have settled down. So I don't know how much of a difference this would make, but for me, a more important thing is how many patients received an encircling band. Because if a patient who's going through a vitrectomy has also got an encircling band, that is going to cause maximum displacement of the retina, because you've completely distorted the ratio of the sclera to the retina. So these are some of the issues which we need to see, whether the proportion of patients who have this displacement is more when you have a combination of vitrectomy plus retinal detachment, plus scleral buckling in any form. It could be in a band, it could be a buckle. And whether these were patients who were failures or non-successes, whatever you can call it, of pneumatic retinopexy with vitrectomy.
So Roxanne, I'll let you answer the first question regarding the changes in the outer retinal bands, whether they were failed pneumatics that were contributing.
Yeah. No, I think the interesting thing is, of course, although the failure rate for pneumatic retinopexy is slightly higher than vitrectomy, this was a small group that we were looking at. But when we came to analyze the data, we realized that the small minority of patients that had these outer retinal changes that had undergone pneumatic retinopexy had undergone a subsequent vitrectomy. So if we were using an intention to treat analysis, we looked at it both ways. So we thought that was quite telling, but it was a small group that we were looking at.
So they didn't have that difference?
No, so ultimately, basically, anyone who had an interdigitation zone or an ELM or EZ discontinuity, they either had a primary vit or they had a failed pneumatic and then went on to vit. The successful pneumatics, almost none of them had.
No, I'm not talking of the successful.
Yeah, but
I'm talking of the failed pneumatics.
Same rate as the primary.
That's the group which may have a disproportionate number of patients who had the changes in your vitrectomy group.
Right.
That's what I'm trying to ask.
Yes, right.
So, because not your successful pneumatics.
But those patients
perfect.
were analyzed in the pneumatic group. They were kept in the pneumatic group. If you had a failed pneumatic and then went to vitrectomy, that remained a pneumatic when we analyzed.
That's not called a.
Yes.
That's not called a vitrectomy group.
No. So the vitrectomy group is only patients who had a first vitrectomy. The pneumatic group was the patients who had primary pneumatic, whether it failed or not. They stayed in the pneumatic group. So the vitrectomy groups are only the primary vitrectomy, and even then, the risk of discontinuity was greater compared to the pneumatic group and their failures.
Okay, and,
Yeah.
and the band was there, was it there? In the
We don't use a lot of encircling band at all, but I do agree with you that the majority of the displacement is not from the change in the shape of the sclera, and we know this because if we take a primary buccal, for example, primary encircling band with no drainage, the rate of displacement is very minimal. So we know that an encircling band alone will not cause a substantial change, but if you move fluid, whether that's with the drainage or with a large gas bubble, you're going to get more displacement.
So probably the best way is to do a partial drainage.
Leave fluid and put a large gas bubble, what's going to happen?
It's still going to
You're
go
gonna
off
get
in the same
displacement.
time as a pneumatic retinopexy.
You'll
The time won't be too different from a pneumatic retinopexy.
Well, so there I disagree. So when you put a patient face down with a small gas bubble, the retina with OCT imaging will see that it'll reattach in about 2 to 3 hours. So it's actually very quick that it can attach. With a vitrectomy, yes, you're not getting the interdigitation zone, but you are more grossly forcing the retina to attach. And these, as Delomo has shown, these corrugations exactly lead to those outer retinal folds. So what we're suggesting is that when you rapidly drain and you don't have time in stage 2 for those corrugations to resolve, that's when you're going to create outer retinal folds with greater proportion. So it's very hard to win with vitrectomy because either on one hand, you try to get rid of all the fluid, you're going to get EZ and ELM problems, you're going to get outer retinal folds.
An alternative could be silicone oil then.
So
Because it doesn't have the buoyancy effect.
Silicone oil
It has
will
only the
minimize
tamponade
displacement.
effect.
Will minimize displacement as long as you don't fully drain. But then you have all the problems with silicone oil. So
Actually, I'm a fan of silicone oil. So, but thanks to that, I mean, I don't see as much of this, and the distortion and all that you're describing. So this is.
It's because if patients can't see well, they won't complain of distortion. So when you have patients who have 20/25 vision, that's when they say that they recognize. If a lot of times patients will not necessarily complain because their visual acuity may not reach that level.
Incidentally, there was one presentation regarding the duration, which mentioned that more than 3 days causes a difference. Was there a difference in the duration of the detachment in the pneumatic retinopexy group versus the...
No, they were randomized. They were randomized, so patients is the same in both groups. But I'd love to talk to you more after as well. Yes.
Thank you. Excuse me, I just want to understand why don't you recommend face up after surgery?
I mean, for the rationale we discussed, the effect of the gas bubble is neutral in a face-down position, and we have data for that. We don't just have data for the face-down position. We would speculate that there would be advantages in the supine positioning immediately post-operatively, and indeed it might be easier to achieve, but we just do not have the data to advocate that. Yeah.
Yes.
First, thank you for the lovely session. Really enjoyed it. Just a simple question came to me. Why you did the AC tapping and the gas in the case when you did the minimal vitrectomy, not going in? Anyway, you are already in
Yes,
the back.
so why did I? Because what we found was that when we modulated the air fluid exchange, let's say I tried a 50% air fluid exchange or a 60 or 70%, I was still getting substantial displacement. It was only when I did only a 0.6 cc bubble that I was able to eliminate the retinal displacement in the minimal vitrectomy cases. And so how do I get a 0.6 cc bubble? By confirming that my eye is closed. If I keep the trocars there and I take out the trocars and you get some fluid leak, now your eye is soft. So what am I going to do? I'm going to have to inject fluid or inject more gas. So I'd rather take out all the trocars, have a closed system so that I can then reliably take out what I want and inject what I want. Exactly.
Okay. So you think it's the thing about pneumatic, or it's 0.6 gas exactly?
0.6 cc is minimum.
Yeah, I mean, it can be done, but this has anything to do with the post-op results, or?
Well, we're going to talk actually in the next session. Now we're going into pneumatic retinopexy in detail. So we're going to show you all the techniques and how you can achieve injecting that much gas. But we do believe that 0.6 minimum is a good amount of SF6 gas.
Oh, thank you.
Start moving
Thank you so much, everybody, for your attention. So we have another course, actually.